Last time we saw how drugs get filtered and how some of them escape back. But what if the body doesn't want for a chance? What if it actively decides you need to go? Today we are talking about the most aggressive part of renal excretion, the tubular secretion. Because some drugs are not filtered, not reabsorbed. They are actively thrown out. So, tubular secretion is the active transfer of drugs from blood to tubular fluid. Happens in proximal tubules. Uses energy-dependent transporter. If a drug's renal clearance is more than 120 ml per minute, GFR, it's not just filtered. It's being secreted. So, the transport system. There are two major pathways. First one, organic acid transport. Next one, organic base transport. Both are non-specific. Both are bidirectional. But for drugs, movement is mainly from blood to urine. Now let's come to the first part. Organic acid transport. Think of this as the exit route for the acidic drug. For example, penicillin, probenecid, uric acid, salicylate, sulfenpyrazone, nitrofurantoin, methotrexate, and drug glucuronides. Organic base transport. For basic drugs, another pathway. For example, thiazides, quinine, procainamide, choline, cimetidine, amiloride, etc. Next, come to the interesting topic of endogenous vs exogenous substances. Now, this is where it gets actually interesting. Exogenous substances such as drugs mostly secreted. Endogenous substances like uric acid mostly reabsorbed. Same transporter, opposite net effect. Now, competition, where generally the clinical magic happens. These transporters are limited, so drugs compete. For example, let's take probenecid, the classic player. Has a high affinity for the organic acid transporter, blocks the secretion of penicillin and uric acid. But this blocking has different outcome. Penicillin normally secreted. When blocking happens, excretion decreased and the duration of action increased. Uric acid normally reabsorbed. But when blocking happens, excretion increased. Same blockade, different outcomes. Because their default pathways are different. Now, let's come to an interesting part, which is drug interaction. Salicylate decrease the uricosuric effect of probenecid sulfenpyrazone. Salicylate decrease the secretion of methotrexate. Probenecid decrease nitrofurantoin in urine, increase the duration of penicillin, decrease the secretion of methotrexate. Now, sulfenpyrazone. It decreases the secretion of tolbutamide. Now the transporters are P-glycoprotein, which is PGP, and MRP2. This located in luminal membrane of proximal tubules. Here is the insight. The quinidine inhibits the P-glycoprotein, decrease the clearance of digoxin, increase the risk of toxicity. And there is exceptions. In newborns, this system isn't ready. Tubular secretion is poorly developed at birth. Drugs like penicillin, cephalosporin, aspirin last longer in neonates. Matures during infancy. So, renal excretion is not just filtration, not just reabsorption. It is also active elimination, where the body doesn't wait, it acts. That's all for the day, people. Thank you for listening.